I have been actively involved in the science communication piece of COVID-19. I did get back of the envelope award funding to do work in the Latinx population of Alabama, work that has since taken off because of interest from partners at UCSF and other places. And so very exciting work, I think, that is soon to be learned about through funding from the School of Public Health from that perspective. A lot of what I'll present today is what I have learned through my science communication as part of work that I do through service for the department, but also the university. And so I really wanted to take you through this journey of what I have learned since I first learned about this in December, started reporting on it as early as January 26th of this year, where we are now and sort of where we need to go. Lots of examples of ways in which you can translate and communicate this information to lay audiences, which I think is where we're lacking. And I'll talk a little bit about that at the end of the talk as well. But feel free to bookmark any of this information or ping me later if it's information that you think would be of interest to the networks that you service or that you're connected to. So just briefly to recap, what is COVID-19? It stands for Coronavirus Disease 2019. You'd be surprised at how many people think that this is the 19th coronavirus that we now know about, not knowing that in fact it's named after the year in which it was discovered. So that's a common misperception about what the 19 after COVID stands for. A lot of people also don't understand that COVID-19 is caused by the SARS-CoV-2 virus. Some people think that COVID-19 is the virus, not understanding that it actually is the disease that is caused by COVID-19. And so much talk and misinformation about, especially lately, about where SARS-CoV-2 came from, how it originated. We know from phylogenetic work that it is 96% genetically similar to SARS-CoV, the first SARS-CoV virus that had been identified years ago, most closely related to the bat and pangolin, we believe. More information about this is reported by Zhu and others in the New England Journal of Medicine, published February 2020. And also misunderstood is that coronaviruses are the family. I always tell people that it's sort of like the name of the family, and then within that there are different viruses that belong, including MERS, or the original SARS from the 2003 outbreak, the common cold, and then the 2019 nCoV, which was the first name that was given to SARS-CoV-2, discovered in China in late 2019, all fall within this family of viruses called coronaviruses. And what's interesting about SARS-CoV-2 is that it's made up from a small set of genes surrounded by fatty lipid molecules. And this became really important early in the pandemic because people were trying to understand how you fought it off, quote unquote, right? This is when the idea of hand washing became really important. There was so much talk about how long it remained on surfaces, how you got rid of it. People were wiping down their groceries, you may recall, with like bleach and other substances. And I think that understanding what comprises the virus and how it's composed is really important, because if you're able to explain to people that it's a small set of genes with this sort of fatty bilayer, that the bilayer is comprised of these particles that can be dissolved by soaps and detergents. So therefore, water and soap are sufficient if you wash your hands for 20 seconds, because this is what helps to break up the virus. But also the ethanol is effective in breaking up the virus, and hand sanitizers, which contain at least 60% ethanol, also very effective. Windex contains detergents. You can also use like a 1 to 10 or a 1 to 5 bleach water solution. But really understanding why that's effective is what I think is missing from our communication to the lay public about why these things work, right? And I think that if we were better communicators about why this would be effective, and sort of this GIF, which I think is pretty informative, that we might have more success with people adapting some of these behaviors. So we know that from several presentations that have been given on campus, many within the COVID-19 seminars that we've had, thanks to Sudeep and Paul and others in the school, we know that SARS-CoV-2 uses the ACE2 receptor to enter target cells. SARS-CoV-2 and SARS-CoV both bind with similar affinities to the ACE2 receptor. Structures of SARS-CoV-2 spike glycoprotein have 2 conformations, and Walls reported in Cell this year that SARS-CoV polyclonal antibodies help inhibit SARS-CoV-2 spike-mediated entry into the cell, which has been really informative for understanding some of the therapeutics that we're currently investigating. This is a schematic that shows basically how the virus enters the cell, how it replicates, and then how it is sort of released into the system in our bodies. This was published by Sevek in BMJ this year. And I thought it was a really nice graphical representation of sort of the process of how this happens. But also important, I think, that after replication and release of the virus in cells, that it leads to these this sort of cluster and not really consistent manifestation of disease in different people. So in some people in lung cells, it leads to non-specific symptoms such as fever, myalgia, headache, and respiratory symptoms. In a hamster model, they saw that the virus causes transient damage to the cells of the olfactory epithelium, which leads to olfactory dysfunction, which may explain why we have that temporary loss of taste and smell commonly seen in COVID-19. This was a really sort of perplexing symptom that many people were reporting, especially because this was not something that was resolving immediately. It was something that was taking some time, even months, to resolve. And that there is a distribution of these ACE2 receptors in different tissues that may explain the sites of infection and patient symptoms. For example, the ACE2 receptor is found on the epithelium of organs such as the intestine and endothelial cells, which may explain why some people have gastrointestinal symptoms only. Other people have cardiovascular complications. We see that lymphocytic endothelitis has been observed in postmortem pathology as well of the lung, heart, kidney, and liver. We also have seen liver cell necrosis and myocardial infarction in patients who died of COVID-19. So it really is just sort of the systemic, in some cases, and non-specific manifestation of pathology depending on who the patient is. So, excuse me, according to the CDC, we know that COVID-19 spreads very easily from person to person, that the majority of spread happens through sort of these droplets that are spewed out when people cough, sneeze, sing, talk, even breathe. They're producing these respiratory droplets that can be therefore transferred to other people, or other people can inhale them and become infected with COVID-19. There is a lot of talk about airborne transmission because some infections can be spread by exposure to the virus in small droplets and particles that can linger in the air for minutes to hours. And there is some evidence that under certain conditions, people with COVID-19 seem to have been infected by others who were more than 6 feet away. The call center study from, I believe it was South Korea, showed that individuals who were not proximal to the index case became infected with COVID-19 with no other explanation for having been exposed. It does appear to spread, as you may already know, less commonly through contact with contaminated surfaces. There are 2 cases, or 2 outbreaks, I should say, in New Zealand that were traced back to a trash can lid and an elevator button They have so few cases in New Zealand that they were able to establish that as the most likely potential source of transmission. However, I would say that it does appear that that is more the exception than the rule. But that's not to say that it doesn't appear to happen, although we don't have causal inference to suggest that it certifiably does. And then there are also cases where COVID-19 rarely spreads that it spreads between people and animals, where some cats and dogs have been reported to be infected with the virus, usually after close contact with someone who had COVID-19. The MDs in the group will know this better than I, and will know that this list is not exhaustive, but excuse me, these are some of the presentations reported by CDC. These are risk factors for that are associated with the development of severe disease, admission to intensive care units, and mortality, older age, hypertension, cardiovascular disease, diabetes, obesity, many of the reasons that I actually also became very intrigued in COVID-19 because of these cardiometabolic manifestations. At presentation, high fever, dyspnea, sepsis, and a number of laboratory markers, including elevated CRP and ferritin, IL-6, and ACE2. We also know that after initial exposure, patients typically develop symptoms on average 2 to 6 days later. This is also a nice graphic from Sevic that was published in the BMJ. There appears to be this pre-symptomatic phase. Jeannie Marazzo, during the COVID-19 symposium, gave some great information about what we recently have learned about asymptomatics, and whether or not asymptomatics remain asymptomatics the entire time, or if they're asymptomatic for some time and then go on to develop some symptoms. A lot of the work that we have done so far, as you know, is very cross-sectional in nature. We don't have a lot of good data following people from before exposure, at exposure, and then after exposure. And so what we know from the data that we have been able to collect over the last 8 to 9 months is that there does appear to be a pre-symptomatic phase up to about 5 days prior to the onset of symptoms. Some people develop only mild to moderate illness, some go on to develop more severe illness, and then others go on to develop very critical illness. So I mentioned that I have been doing some science communication for some time, and I write this series called Science Says Sundays on my blog. I have done most of that on the actual blog, but it's transitioned more so to Instagram because that's where I tend to capture the largest audience for this information. And on January 26th, I wrote a blog post sort of detailing what we knew about the coronavirus outbreak. And I said, as I write this, there are a total of 5 cases reported in the US. You currently have more reason to worry about the flu. We're not yet facing a pandemic, at least not yet. And I totally ate my words because obviously, as you know, so much has happened then, and we are definitely not, we definitely transitioned to very much a pandemic classification for COVID-19 or the SARS-CoV-2 pandemic. This was also a graphic that I created very early on. This was published March 29, 2020, where I was really trying to find a way to communicate to lay audiences sort of why the stay-at-home orders were so important, what was lacking, why it was important to enforce social and physical distancing, and the degree of response needed indicated that we needed a lot of social distancing at the time because we did not have a lot of testing. At the time, we also thought we needed a lot of ICU beds and ventilators, especially ventilators. They were a big subject of conversation. Face masks were still sort of very conflicting information about them. The antibody tests were coming on the market and there was a lot of ambiguity about that, but we thought they might be useful and definitely very much in a different context because at the time we didn't fully understand how long people would have antibody responses that would be picked up by a test, antiviral treatment, etc. And so, gosh, this is messing up. And if you move the levers, then that would change the amount of, in this case, for example, social distancing that was required if you were able to provide face masks, ICU ventilators, COVID testing, et cetera. And so that we would be able to move ourselves from more of that social distancing need to be able to resume quote unquote normal activities. And as I was putting this talk together, I came across this blog post also written in April by someone from Morgan Stanley. And this was what was projected to happen, right? So that in April, late April, we would sort of peak. And then because of antiviral trial results, we would increase testing capacity at 500,000 per day. We'd then have testing capacity at 1 million per day, close to June. We'd have public health departments fully staffed by midsummer. You know, I keep thinking like, you know, I was personally so naive, thinking we just had this under control and all of this would be possible. And really only expecting a potential second wave of infections during when the season when we typically see colds and flu and all of the other co-infections that are possible along with COVID-19. And unfortunately, what we have seen is that COVID-19 cases have grown rather exponentially over time, with the Americas leading in the number of confirmed cases, followed by Europe and Southeast Asia. And in April, I gave a talk about COVID-19 where we had about 1.5 million confirmed cases in worldwide, 82,000 deaths as of today. 46 million cases, and we have over 1 million deaths. In the US, we had 12,000 deaths recorded April 8th of 2020. And today, this screenshot reports 231,000 deaths due to COVID-19 in the US. In Alabama, at the time, there was this great GIS tracker that the Alabama Department of Health had out. We had 2,000 confirmed cases. We'd had about 14,000 people tested. And at the time, we only had 64 reported deaths confirmed due to COVID-19. And as of today, or actually yesterday, this is yesterday's data from BAMA Tracker, who has been a great third-party tracker of COVID-19 cases. We've had 193,000, almost 194,000 confirmed cases due to COVID-19, over almost 3,000 deaths confirmed due to COVID-19. And yesterday, 1,700 cases were reported, with 944 of those confirmed and 756 probable COVID-19 cases. This is from the Johns Hopkins University tracker system, which is reporting the 7-day moving average for cases for a number of countries, the US included. And you see that we have about an 80,000 7-day moving average for the US, higher than any other country listed here so far. This green one is the US. India had a very quick surge, and they seem to have peaked and are now on the decline. This orange is France, and then you see some of the other European countries like Italy, who's in red here, also seeing an increase, but nowhere near what you're seeing in the US. And one might wonder why. A lot has to do, obviously, with mobility. So this is data from Apple that indicated what they saw in terms of mobility patterns among Apple users. You see the decrease in activity due to lockdowns and stay-at-home orders that happened in March and April. This line represents the baseline. So you see that there was above average activity before the lockdowns and stay-at-home orders. And then it didn't really return to normal. It sort of went above and beyond normal. It did coincide with the summer months and returns to school. And so it's unclear exactly what led to that. But you do see that there now appears to be a decline, more consistent with what we saw in the earlier months, January to March. Which could mean that there was that summer travel, school-related travel, et cetera. Also interesting is this COVIDcast data that conducted a survey about face mask use. So on Facebook, they conducted a survey asking people if they were wearing their masks most or all of the time, because there have been some associations and correlations established with respect to mask usage and how much COVID-19 you are seeing either in the city or state or country. And you see some good reporting of most or all of the time mask wearing on the West Coast. Is where you see sort of that blue teal color. The green is indicating on the 66 to 70% usage. And then in the Northeast, there is reports of greater mask usage. And you see other reports that are presented in the media like this, where the most recent one was published in October 19th in the Washington Post. The problem is that this type of information really causes, I think, a lot of confusion in the public who doesn't understand the nuance of ecological studies. And, you know, an ecological study sort of looks at observational data that's analyzed at the group or population rather than the individual level. And this can lead to some ecological fallacy because there's just this inherent sort of logical error that happens when you have analysis that is analyzed at that group level and incorrectly assumed to also hold at the individual level. Sorry. So there's a number of other characteristics and factors that are happening in all of these states. Population size, unfortunately, but you know, political leanings, how the level of social cohesion, for example, all contribute to whether or not this may or may not be true. And so I would say that we know that masking is good, but when you see reports like this, recognize that it may be subject to some ecological fallacy. And so we know from data in Alabama and other places, there have been studies now that have been published on the efficacy of masking and how well it is leading in conjunction with or together with some of the other mitigation strategies that we have in place. Physical distancing, washing your hands, watching your distance from others, avoiding sort of indoor spaces. All of those together are really helping to decrease COVID-19 spread. But whereas we were very early on trying to flatten the curve, quote unquote, it's very clear in the US that we failed to truly do that. We seem to have come down a bit after this first wave, really surged for a potential second wave, although in order for it to have been a true second wave, our decline should have come down really almost to baseline. And we never fully achieved that. And so now what we're seeing is sort of this third peak emerging, which may or may not be a true third wave, because again, we never actually made it down to baseline at either point in either of these two peaks. And a lot of this is attributed to sort of the patchwork approach that we took in the US with respect to reopenings, to testing, to communication about how you prevent COVID-19. And so the lack of coordinated response is in some ways really related to what we're seeing in the US. There was a lot of talk in lay circles also about why we didn't seem to see the similar trends or peaks with respect to COVID-19 deaths. And a lot of this had to do with some of the wonderful work that our physician colleagues and others in the medical profession have been doing, and scientific profession too, right? And understanding how to treat COVID-19 in hospitals. Many states, UAB included, as a hospital, has done a phenomenal job of really preparing and understanding how to mitigate the influx of patients so that they can ensure that all people that come to the hospital are treated well, then they have good health outcomes. But there was a little bit of the sort of this lead time bias that was associated with why we saw a lag in deaths after that first surge of COVID cases in the US. And so it has, often we see lead time bias when we talk about like cancer screening, for example. With SARS-CoV-2, once we moved from symptom-only testing and we started to test people who not only had COVID symptoms, but anyone who maybe who had been exposed, who wanted to get testing, et cetera, then you had more people and more lead time, if you will, to that time when you would detect deaths that were due to COVID-19. And so this could in part help explain why we were seeing a lag between cases after a surge, especially when we see that there does seem to be a general lag of like 2 to 6 weeks later after seeing a COVID-19 peak in our data. So in Alabama, COVID-19 cases, we saw a peak around July 19th, and the peak for deaths due to COVID-19 happened a few weeks later, with August 6th at about the peak that was identified based on this BAMA tracker data. The great thing about BAMA tracker is that they now have, well, it's one guy that runs it, has the ability to look at deaths by date. So the number of deaths that are reported seem to come in these clumps of data, and he has now been able to take the deaths that have been reported on a given day and assign them accordingly. And so that's what this chart is reporting here. We've also seen with COVID-19 that there has been sort of more of this bimodal distribution with respect to who is affected and who becomes a case for COVID-19, with deaths really being more skewed still towards those older age groups. With respect to race ethnicity, we see that there is a significant number of individuals who correspond to the Hispanic and non-Hispanic Black category that follow those cases that we see in high proportion within the white category. With respect to deaths, the similar trends appear. However, when you look at the COVID tracking project and you look at deaths per 100,000, you see that Black people are dying at 2.2 times the rate of white people. And the CDC MMWR recently also reported that there is an increase in excess deaths. So the largest percentage increases for COVID-19 deaths happened among individuals who are Hispanic or Latino in adults aged 25 to 44 years of age, which when you look back at that data for age groups of individuals who succumbed to COVID-19, you see that it was disproportionately sort of in that older category. With Hispanic Latinos, at least 2 out of the 3 excess deaths were from COVID-19. And this was data from late January to early October. So significant health disparities, especially with respect to race ethnicity associated with COVID-19. JAMA presented or published this really nice paper also in report on excess deaths from COVID-19 and other causes dating between March and July of 2020. These were selected states that were reported in this paper, and the 10 states with the largest number of excess deaths between March and July 2020 included Texas, Florida, and Arizona, Pennsylvania, Massachusetts, Illinois, Michigan, New Jersey, New York, and California. So this is where I think I'd like to spend some time having a conversation afterwards, because COVID-19 is spread, as we know, by individuals, so individual to individual primarily. One thing that I think is misunderstood and that we've only recently begun to really understand about COVID-19 is that there are individuals with what they call super spreader ability, and that they're not like, that's kind of a misleading title or designation, I would say, because it seems like maybe they have more virus, or it's not truly understood, I think, what that super spreader categorization or designation means. But what has been reported is that by some estimates, 10% of people have caused about 80% of new infections. And Lau in PNAS reported that about 2% of cases were directly responsible for about 20% of all infections. And so it does appear that there are situations where, I don't know what just happened, where one or more individuals do appear to be leading to a number of infections that are not an average that we would normally capture through this R naught that we talked about very early on in the pandemic. So the R number represents the average number of people an infected person goes on to infect. And very early on in the pandemic, a lot of our science communication centered around this idea or graphic that like one person would go on to infect 3 others, and those 3 others would go on to infect, et cetera. And what we've seen through some of the data that we worked on collectively, or that we have seen collectively, is that that seems to be less the case with COVID-19 in some cases. So here is the RT Live that many people will report. We have it on our BAMAtracker.com tracking page, where if the R is larger than 1, the number of people with disease is increasing. And so for control strategies, including lockdowns, self-isolation, and mask wearing, you want to bring that R below 1, sort of where Mississippi and Florida appear to be. That is a little bit misleading, I think, because of the nature of the way that COVID-19 spreads, but also because we still continue to undertest people. There are a lot of factors that are resulting in an incorrect, I would say, R naught. And so what we've learned is that after 9 months of collecting this data, this appears to be more of an over-dispersed pathogen rather than a more evenly dispersed pathogen, meaning that it tends to spread in clusters. And we haven't yet fully understood how that happens, but we have a number of cases where we understand that in acquired practice, one person infected a number of people, that at summer camps, there was a similar spread. And I think that we have yet to transition into that frame of thinking with respect to this particular pandemic. So what does that mean? It means that how we have been contact tracing sort of in this forward manner, where you take someone who is COVID positive and you move forward and in identifying all of the people that they were around as contacts, may be less efficacious, given that we should really be maybe focusing on the places and populations and groups of people that may lead to these super spreading events, and then work our way backwards to try and prevent those. And so that has resulted in some talk about the difference between forward tracing, which we're used to doing and a lot of health departments engage in, and instead transitioning to this idea of backward tracing, where you may be able to increase the number of traceable individuals by a factor of 2 or 3, because index cases are more likely to come from clusters rather than a case is able to generate a cluster. And so far we have evidence about these super spreader events or places, or these places having the capacity to be super spreader events. There is now a lot of data suggesting households. Households actually were reported very early on in the pandemic as well, but also household environments. Prisons, worker dormitories, long-term care facilities, homeless shelters, nursing homes and prisons. And again, not all at all times will have this capacity, because you sort of have to have the timing of an individual who's COVID positive, who will infect a number of people, and that may not happen every day, right? It depends on community spread as well. So how much COVID-19 spread you have in your community. And so what are the odds that that would happen at any given point is sort of what is really hard to communicate to the public as well. Places where you have many close contacts over a period of time, so like choir practice, the CDC in this science article had department stores listed as well, which was really surprising to me. We know church events to be the case, but also healthcare settings. And transmission does seem to be amplified if multiple subsequent infections happen in rapid succession. So we have outbreaks reported in schools, meat processing plants, and again, churches, as reported by Lee in this science article. And they again don't happen all at one time. We have outbreaks sort of popping up at not all within the same time frame. Many of the reasons why in Alabama, when you see those maps that are reported by the Alabama Department of Health, we may have some areas that are green and some areas that are that dark red. This was taken from the New York Times Interactive, where it shows you the average daily cases in the US. And you see that in some places you have some red spots, with a lot of areas that are either yellow or that orange, and that may shift over time. Right now, as you know, we have a pretty dire situation in Wisconsin, also Tennessee, so they tend to have a lot of that darker red. But in other places like Alabama, for example, we only have some places that are red with a really general distribution of colors with respect to averages of new daily cases. And so ultimately, I think this means that we should take that knowledge to really inform what we do moving forward. Because our policies for preventing SARS-CoV-2 transmission right now focus on this forward tracing, on this isolating individuals who are positive, which is all really important as well. I think we also need to consider the benefits of backward tracing, because that may be a way to prevent other super spreading events, and also be able to more concretely identify the places that people should know about with respect to preventing or becoming infected themselves. So we talked a little bit about manifestations of COVID-19 infection and how we classify cases, but I think something that's been failed to be communicated to the public as well is that a lot of the information that we have is on individuals who made it to hospitals, and also largely adults. We don't have as much information on kids, and there does seem to be this this case selection bias, wherein selection bias occurs when individuals or groups in a study differ systematically from the population of interest, leading to systematic error in an association or outcome. And a lot of what we have studied and a lot of what we have seen has been in adult populations. And Shay During gave a really nice talk last week on sort of what we know and don't know in kids. And he and others have reported that the spectrum of disease in kids really varies, and kids that come in testing positive for COVID-19 can present with croup, bronchiolitis, pneumonia, gastroenteritis, strep throat, just seeming like they have a cold, feeling completely normal. And so they have this really like non-standard presentation for the most part, with some having cough, fever, and respiratory symptoms. And we do know that most kids do well with COVID-19, but young infants and children with chronic medical conditions do seem to be vulnerable to COVID-19. Fever, along with decreased oral intake, was reported by Shadering to be the most common at presentation to medical settings. And then, of course, we have what many have heard about, which is this multisystemic inflammatory syndrome in kids. Very early on, it was, 5 cases maybe that had been reported. I recall early reports from New York saying they had identified 3 or 4 like in March or April. Now we have about 1,000, almost 1,100 across the US, and 20 deaths that have been reported as a result of MSIC. So my takeaway from the literature of kids and some of the MMW reports that have been presented by the CDC is that kids are both susceptible and can transmit. And 2 of the classic studies that I point to for this are the main camp outbreak, which to me signaled that kids were susceptible. It seemed to me, based on the timing, that the camp counselors most likely passed it on to the campers that arrived, but also that they're able to transmit. This MMW report suggested that in children who got COVID-19 at 2 Utah child care centers, spread it to other household members based on some tracking that they were able to do. And in general, we know and have heard about this asymptomatic phase or presentation of COVID-19. Another great MMWR report showing that 238 young adult US service members on a naval aircraft tested positive for current or previous COVID-19, and only 1 of the 5 reported no symptoms, but I think consistent with what we've seen in other reports and at other publications. And then a lot more talk recently about COVID-19, what they call long haulers. And that is that recovery from COVID-19 can take a long time, even in young adults with no chronic conditions. And so this MMWR report suggested that 1 in 5 previously healthy young adults weren't back to usual health 14 to 21 days after testing positive. So we're getting close to the end, and so I'm just going to do a recap. So we know that SARS-CoV-2 is genetically similar to SARS-CoV-1, but characteristics of SARS-CoV-2, for example, those structural differences in its surface proteins and viral load kinetics may help why it has this enhanced rate of transmission. In the respiratory tract, peak SARS-CoV-2 load is observed at the time of symptom onset or in the first week of illness, and then there appears to be the subsequent decline thereafter, indicating highest infectiousness potential either just before or within the first 5 days of symptom onset. In one publication I read from kids, the PCR test appeared to pick up the greatest number of SARS-CoV-2 viral particles in the first 2 days of infection. PCR tests can detect viral SARS-CoV-2 in the upper respiratory tract for a mean of 17 days. However, just because you detect viral RNA doesn't mean that you're necessarily infectious. And I think that's really important also to communicate to lay audiences, is that picking it up on a test that far out, I've heard from a number of people say, well, I had COVID-19 and I'm still testing positive. It's important to explain to them that the test may be still picking up those viral fragments, but it doesn't necessarily mean that they are infectious. In fact, it seems that viral, especially upper respiratory tract samples, are rarely positive beyond 9 days of illness. Symptomatic and pre-symptomatic transmission 1 to 2 days before symptom onset is likely to play a greater role in the spread of COVID-19 than asymptomatic transmission, but I'm not sure that we know how well that happens. And I will pause to also say that with kids, even though we know that they're susceptible and can transmit, How well they do that is also largely unknown at this time. And we know about a number of virus neutralizing antibodies that have been reported, and emerging evidence seems to suggest these correlate with severity of illness, but then wane over time. So Berlin published this really nice incubation and symptom onset graphic. This was reported in New England Journal of Medicine that I have shared with others when they have questions about median days of infection to onset of symptoms, and why that 14-day quarantine period is so important. A lot of people are asking about this right now with the holidays coming up. They want to know, can I get tested before I go see my family? They want to know if they need to quarantine. Do they need to quarantine before, or do they need to quarantine after? And I think explaining sort of, why that 14-day quarantine period is so important, where exposures can happen, how testing works currently, all of those things are really going to help people make those decisions as we face the upcoming holidays. This struck some really interesting conversations recently because CDC changed their communication or guidance about what a close contact meant based on this case of a correctional employee that developed COVID-19 after several brief exposures to infected, incarcerated people. The individuals who had come from a different facility and were doing sort of intake at the facility where this correctional employee worked. They did not yet know, they were awaiting COVID-19 results. They did not yet know that they were positive. However, during this 8-hour shift, the employee was exposed to 6 incarcerated people multiple times for a minute or less before they knew they were infected. And so that led to a change in the verbiage. Whereas before, CDC seemed to communicate that you needed a full continuous 15 minutes of exposure to somebody. This seemed to suggest that it wasn't 15 minutes with one person, but rather that sort of these multiple exposures, even if with different people who were positive, might accumulate to exposure for an individual, and consider multiple contacts as part of the exposure to a person. And so this made it in the news because there was a lot of question about, in that forward tracing, now that increases potentially the number of people that you have to list as a close contact, especially if you didn't just have to spend 15 minutes total at once with an individual to classify them as a close contact. So for future research, I think it's really still important to understand what the role of cytokine storm that we hear about is, and how it can inform the development of therapeutics, vaccines, and supportive care, which I didn't even talk about today. That is so not my area of expertise, and so I leave that to others who present in the seminar series or across campus to comment on. What is the period during when patients are most infectious, I think is also really important. We have to really define that. And all patients, so not just adults, but also kids, because I think they're a highly understudied population. And speaking of kids, why do some patients develop severe disease while others, especially children, remain mildly symptomatic or do not develop symptoms at all? And what are the determinants of healthy versus dysfunctional response, and the biomarkers to define immune correlates to protection and disease severity for the effective triage of patients? And then finally, what is that protective role of T-cell immunity and duration of antibody and T-cell responses? And how do you define the correlates of protection? I think is really important to define as we move forward. So a colleague created this as a great graphic to share with people. Ian McKay has this website called RIology Down Under, and along with a number of people, I think we're able to create something that really helps understand both personal and shared responsibilities and how each intervention layer has imperfections. But if you're able to put all of the layers together, physical distancing, mask, hand hygiene, not touching your face, avoiding crowded spaces, fast and sensitive testing and tracing, ventilations, which is a really important factor, I think, prioritizing outdoors, which is really hard now that winter is coming for some states, air filtration in buildings and classrooms and so forth, that government messaging and financial support, appropriate quarantine and isolation, then ultimately, of course, vaccines, all to try and prevent COVID-19. So it's not just a one single approach that's going to help us curb this pandemic, but rather a combination of a number of things. Also in collaboration with the Boston University COVID-19 Response Corps, I worked on an FAQ listicle that we were able to publish via social media, but also share with a number of media outlets to sort of help people navigate how they're going to plan for the holidays. A lot of people are worried that the holidays are canceled. And while I think that we face really uncertain times in the upcoming months, that there are some ways in which you can do that safely. And so more information is located there. Ultimately, I do want to make a call. I know that it's really hard to sort of break outside of our academic circles and talk to people, especially lay audiences about this, but we are, in addition to fighting a pandemic, really fighting an infodemic, so much so that the World Health Organization made a comment about it. And the very technology that we rely on to keep connected and informed is also enabling and amplifying the infodemic that continues to undermine that global response and jeopardizes measures to control. So it's really important that, I'm not advocating necessarily that you get into fights with people on Facebook, but if you are able to put out information and talk to people about existing rumors and sort of help understand why those rumors are rumors and not evidence-based information, I think that would help to sort of decrease the amount of misinformation that's out there generally. Because we've had things like this happen where between May and June, 15 people in Arizona and New Mexico were hospitalized for swallowing hand sanitizer, which included methanol. And so it's this misunderstanding of what you should and should not be doing that is also causing unintended harm in people. Finally, a reminder from Tom Frieden, former CDC director, that by Thanksgiving, more than 250,000 Americans will have been killed by COVID-19. No words can bring them back. Actions can now prevent tens of thousands of additional deaths. Many of you know my uncle passed away from COVID-19 now about 3 weeks ago. Healthy, 70-year-old-ish person. And so I think that it is unfortunate that people are succumbing to COVID-19 when so much of this was preventable.